Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Patterns of Care, exploring how community-based general medical oncologists manage metastatic triple-negative breast cancer. We have a great faculty today, Professor Peter Schmid from the Barts Cancer Institute in London, United Kingdom, and Dr. Melinda Telli from the Stanford Cancer Institute in Stanford, California. Today we're talking about triple-negative breast cancer and metastatic disease in particular. As in all of our programs, we will be talking about the use of unapproved agents and regimens, so check out the package inserts for more. Here's where we're heading. We're going to start out with really one of the most important, particularly evolving topics in triple-negative disease, the use of Trop-2 antibody-drug conjugates. Then we'll get into first-line therapy, first in the PD-1 negative situation, then positive. Then we'll get into sequencing, even multiple ADCs. And then we'll finish out with some discussion on adverse events and how they can be prevented and managed. So, all of our programs, we're trying to provide information that's really going to be helpful to people in practice. And tonight we'll not only be going through some research findings, but also clinical scenarios. People tell us our stuff's a lot like the boards, and that's what the boards are. So we'll talk about scenarios and what's going on and what you do about it. But also we're going to present some cases, real-world cases from a survey we did in April. We did a previous webinar on some of the data from this survey. We had 50 community-based general medical oncologists. We asked them a bunch of questions that we're going to ask our faculty tonight, but we also asked them for cases from their practices. We'll see how many of these we can get through. So I want to start out with a little bit of an introduction, and both of the faculty will be presenting slides on and off here tonight. We'll start out here with Peter, talking a little bit about where Trop-2 ADCs are heading in metastatic breast cancer. Take it away, Peter.
Thank you, Neil. Just before we start, just take us a step back. Where have you come from with metastatic triple-negative breast cancer? These are the outcome data only 10 years ago. And we saw that on average, if triple-negative breast cancer comes back, on average, it comes back after about 18 months, 2 years. And the data back then, first-line chemotherapy, the average time was 3 months, 12 weeks of therapy. Only 3 out of 4 patients were well enough to make it to second-line therapy and stayed on average on there for 2 months. And only half of the patients would be well enough for third-line treatment, and again, stayed on average on that treatment for about 4 weeks. So only 10 years ago, the median survival of this disease was about 1 year. And what I would like you to take away today is really how dramatically this has shifted. If you look at some of the ADC data, the first-line response, the duration of response is much longer than what we used to see as overall survival in those patients. One of the reasons why it took us a while to crack triple-negative breast cancer was as we looked at it as one disease type, but it's quite a heterogeneous group with various different biological subtypes. And the initial attempts to classify this by gene expression subtypes were interesting. It sharpened our mind in understanding biology, but therapeutically, they are not relevant. What's relevant therapeutically is looking at the different treatment strategies, the associated targets or target populations, for example, PD-1 positive for immune therapy or germline BRCA positive for PARP inhibitors. But when we focus on the ADCs, again, there has been a shift. We are no longer focusing on targeting oncogenic drivers as we used to do in HER2 high disease. It's now any target that's on cancer cell. And I think really important clinically, these different subgroups are overlapping. You can't say I have a BRCA positive patients and you know everything about it. You have to look at each of those targets. So PD-1 positive patients with a germline BRCA mutation, Trop-2 high, HER2 low, androgen receptor positive, and then allows you to select the right treatments. And we can talk about how we best sequence those treatments going forward. Looking at some of the targeted drugs we had prior to the ADCs, PARP inhibitors showed a good benefit with a hazard ratio of around 0.53, 0.54, but relatively short progression-free survival. What is still impressive is the response rates with PARP inhibitors, but we achieve similar things with platinum and platinum-sensitive disease. And again, a question that may come up in one of the cases as well, can we go beyond germline mutations and look for somatic mutations of BRCA, also PALB2 mutations? The second targeted therapy we established in TNBC was immune therapy. And we saw clearly that the addition of immune therapy to chemotherapy improves long-term outcome in terms of survival, but only in those tumors that are PD-1 positive, whether it's with the SP142 assay on the left side or the CPS assay on the right side. Now, the ADCs are a group of drugs you're all very much familiar with, but the latest generation of ADCs really combines some new biological effects. The old-fashioned concept and our understanding of how these drugs work is they bind to the surface of the cancer cells, get internalized, broken down, and the chemotherapy gets released inside the cell. But with the latest generation, this drug can diffuse outside the cell again and can basically kill target-negative cells as well. And that's the basis for something calling the bystander effect, which is really what's driving this incredibly enhanced activity compared to previous generations of ADCs. These are the TROP2 targeting drugs we are using in breast cancer at the moment. 2 of them approved in some parts of the world, sacituzumab govitecan on the left, in the middle, Dato-DXd, and then still an experimental drug, although with positive phase 3 data, sac-TMT. And as you can see, there are similarities between those drugs. They all 3 have a topoisomerase 1 inhibitor payload, so similar chemotherapy there. They also have a similar biology for the linker cleavage, although there are differences. And if you look at the half-life, for example, sacituzumab govitecan, much shorter half-life with 11 to 14 hours compared to Dato-DXd. And that's down to the stability ultimately of the linker connection. That's also reflected in the different regimens. Sacituzumab govitecan day 1 and day 8 every 3 weeks, whereas Dato-DXd is given every 3 weeks and sac-TMT given every 2 weeks.
So before we get into more data, I want to just take a breath. Again, we're going to go back and forth between cases and scenarios. And Melinda, when we talk about the real world, here's a case that was submitted by one of the oncologists, a 58-year-old woman. And then once you get into the real world, you start seeing things like this. This lady had a prior history of diffuse large B-cell lymphoma. She was in complete remission, but she had a history of cardiomyopathy and heart failure, had a pacemaker. She did present with triple-negative breast cancer, got neoadjuvant therapy, ended up with progressing not long after that, and was put on sacituzumab. And the thing that really struck me about this, Melinda, is this patient was I think is still on sacituzumab in 4 years. Very unusual, really a great response. So I guess one question I wanted to ask about this is, how do we identify a patient like this compared to someone who has a short PFS? We've talked about TROP2 levels. Is that any clue, any other clues? How often do you see these type of prolonged responses to ADCs, and any predictors of it, Melinda?
Yeah, I agree. This is a really unusual case. I haven't myself seen a patient on SG for that duration of time. But sometimes we do see these exceptional responses. I think that, there was a lot of investigation about TROP2 levels. We know that it's highly expressed epithelial marker on a number of different cancers, and in breast cancer across breast cancer subtypes. And so, that correlative data has not translated clinically into some sort of test or marker that we should assess to identify patients more or less likely to respond to SG. And so it is reported on some assays that you can get next generation sequencing and immune histochemistry, but really not something that's required for treatment selection. I think, remarkable response. We love it when we see this.
So, Peter, this doc also wants to know if and when this patient progresses, what's next, particularly with this history of heart failure. This patient is, quote, HER2 negative. I guess that means HER2 zero. But I'm just kind of curious, would you give TDXD to a patient with history of heart failure, Peter?
It's probably not your treatment of first choice. I mean, we know it depends on how significant the heart failure is, but obviously all HER2 targeting drugs have a risk of cardiotoxicity, and I think we need to be careful. The other thing to consider is that a lot of the resistance to ADCs is driven by the payload. This patient's had a very long response to a topoisomerase 1 payload ADC. And that suggests it's probably, again, the resistance to the payload rather than to the target. So giving TDXD is probably not the most effective and most promising strategy. We would often give, for example, eribulin in patients after SG, and that can be a very effective treatment.
That's a great point. Melinda, how about this patient, 71 years old, de novo, triple negative disease, PD-1 negative, extensive liver mets, peritoneal disease, the patient's sick, performance status 2, bordering on 3, a little bit older. I mean, 71 is not that old, but sort of visceral crisis type situation. Any thoughts about therapy in this situation where really the performance status is getting driven by the tumor and maybe an otherwise healthy patient? You still think about the same first-line approach, Melinda?
Yeah, I mean, I think she, is 71, definitely has medical comorbidity with atrial fibrillation, diabetes, poor performance status, but as you mentioned, probably related to just significant disease. So this is a case where I think, do we want to give something IV as she's having lots of GI toxicities? Capecitabine probably wouldn't be a good choice given all of that. And so an IV therapy where we can get a rapid and high likelihood of a nice deep response. And so I think, your options here are to lead with an ADC, or if there's concern about tolerability toxicities, a taxane, a platinum-based chemotherapy regimen could be considered. But I think based on the data we'll talk about, this is really the space for TROP2 ADC.
So I just want to put that out there to keep in mind, again, how this disease presents in the real world. It's never as simple as these scenarios we talk about. But Peter, next topic here is TROP2 ADCs in the first-line metastatic setting. And we're going to start out talking about just a little bit of an overview in terms of PD-1 negative versus positive, Peter.
Yes, thank you, Neil. Well, let's start with the PD-1 negatives, but just to show you the trials that have been ongoing and the trials are still ongoing. We have had 2 positive trials in PD-1 negative disease with an ADC SG on the left, Data-DXd on the right, compared to standard of care chemotherapy. There are other trials ongoing to Fuse 11 with SAC-TMT. And again, interesting in that although PD-1 negative, it will also look at the contribution of pembrolizumab, trying to see whether we can overcome that paradigm that immunotherapy only works in PD-1 positive tumors. A second trial, it's our own trial, again, Data-DXd plus minus an immune checkpoint inhibitor. And then I've put that in. It's a topoisomerase 1 ADC, but not targeting TROP2 with ISABRITE, a different ADC targeting HER1 and HER3. If you look at PD-1 positive disease, again, very symmetrical with the same concept of trial. Ascent 04 has reported data as SG plus pembro versus chemotherapy plus pembro, and then TROPION-Breast05 still ongoing, same trial, just with Data-DXd plus checkpoint inhibitor versus chemotherapy and checkpoint inhibitor. If you look briefly at the PD-1 negative trials, this was the TROPION-Breast02 trial presented a few months ago for the first time, first-line setting, Data-DXd versus standard of care chemotherapy. And I think really important for us as clinicians, it had a substantial fraction of patients with very early disease. This is something we see increasingly as we cure more patients with Keynote 522 and our more effective treatments. Those patients who have disease recurrence often relapse earlier and have more aggressive disease. So this is a real strength of this trial. On the other hand, one of the downsides of the trial is only 42% of patients were crossing over subsequently to a different TOP1 and TROP2 target ADC. And I think that is important to consider when we look at the overall survival data. Progression-free survival, clearly significant, meaningful improvement. You can see the median PFS is more than 10 months compared to under 6 months with chemotherapy. And again, that needs to be seen in the context of what I said earlier with an overall survival we had a few years ago of only 1 year. We saw at ASCO the update for all the other efficacy endpoints, PFS2, time to subsequent treatment, and you see that trend goes through all the subgroups and all the endpoints. Looking at overall survival, this trial showed a significant and meaningful improvement in overall survival. The delta is about 5 months. If you look at the forest plot, it looks superficially relatively similar across all subgroups. But if you zoom in at the country where patients were treated, US, Canada, Europe, there was no clear survival benefit. Rest of the world, there was. And what's the difference between those regions? It's probably access to TROP2 ADCs in a second, third line setting. So if you don't give it first line, you may still have the similar benefit in a second, third line setting, is my takeaway from that. Safety data, it is targeted chemotherapy. We see some side effects more with ADC compared to standard chemotherapy. Otherwise, for example, stomatitis is a feature of Dato-DXd. We see, on the other hand, a lower rate of neutropenia with this 3-weekly treatment regimen. If you look at the quality of life, we saw a few months ago, the time to deterioration of quality of life is better with Dato-DXd compared to standard chemotherapy. Again, I think that's really important for everyone in community practice. So time to deterioration of global health status, quality of life, time to deterioration of physical functioning, so patients being active in the community roles. And then looking at some of the side effects, the fatigue and stomatitis is two of the key side effects, how much patients were bothered by it. And actually the impact on the quality of life from a patient perspective was relatively low. If you look at the second trial in the first line setting, PD-1 negative patients here now with sacituzumab govitecan versus standard chemotherapy, subtle differences. This trial didn't allow patients who relapsed within 6 months from the end of their adjuvant chemotherapy. On the other hand, crossover was funded. So even patients in countries where they couldn't afford having sacituzumab govitecan at a later line got it. And you can see 82% compared to the 42% had a subsequent ADC. And that, of course, has an impact on overall survival. If you look at the progression-free survival data, they look very similar hazard ratios, similar benefit. And again, if we look at the subgroups, there's nothing that really sticks out. We assessed PFS by TROP2 status here at ASCO this year. And as you can see, of course, the efficacy may be slightly higher in patients with high TROP2 expression. But at the same time, even in patients with low TROP2 expression, sacituzumab is still more effective than standard chemotherapy. Overall survival data are immature at this point in time. Progression-free survival shows the benefit is carried over into the next line of therapy, which I think is important for patients. Looking at the safety profile, different to Dato-DXd. Each ADC has their own unique safety profile. We see more gastrointestinal toxicity, diarrhea, nausea. We see, again, in this trial, more neutropenia, but this trial didn't consider everyone for prophylactic G-CSF, which is something we can possibly discuss later on when we go through those cases.
So, Melinda, we seem like we're in a similar situation with ER-positive, HER2-negative disease, where you have two TROP2 ADCs with similar data. So here's the kind of a scenario that I'm putting out to you. And basically, the patient is HER2 low, but PD-1 negative, BRCA wild type, metastatic disease. Right now, how are you deciding on first-line therapy in these patients? And particularly, how are you choosing between Dato and SG in these patients? And how do some of these other variables like the symptom status, cytomets, or brain mets affect your decision, Melinda?
I think that both agents are highly active and I think very appropriate for use in a typical patient in the first line setting. I think some of the things we talk to the patients about, it's really the schedule, sort of the distribution of the side effects. Sometimes certain patients find certain toxicities more or less acceptable to them. I think with Dato-DXd, there is a requirement for an upfront ophthalmology assessment, which in certain communities can be challenging to get patients in, and so may affect utilization, I think, potentially of that drug. But, the other sort of quality of life things with Dato-DXd, we're going to talk a little bit about eye drop prophylaxis, oral mouth rinse for the stomatitis prophylaxis. Some of these things are different. And so a lot of times when presenting a patient, they pick, with our guidance, sort of what feels kind of most acceptable to them. There is alopecia with both agents. Sometimes that's a big factor for patients when trying to make this decision.
So, Peter, anything you want to add to that? Do the site of metastasis or symptom status affect it? And then what about this scenario? Same situation with PD-1 negative, but now the patient has a BRCA mutation, either somatic or germline. How are you thinking about first-line therapy here, Peter?
Yeah, Neil, it's a really important a case. And I think the question I always have to ask in this situation, have you just got one shot on goal? If this is a situation where you have one treatment and you need to nail it with one treatment, you need to use the most effective therapy. And that's symptomatic visceral metastasis. I would normally opt for the ADC. But it's very different if you have a patient with asymptomatic bone metastasis. You don't necessarily need to induce a very rapid response. And for example, this patient now being BRCA mutant, I think it is entirely reasonable to give a PARP inhibitor to this patient, especially with de novo disease. With de novo disease, metastatic disease, the response rate with a PARP inhibitor is around 65 to 68%. So these are also highly effective therapies, orally available, very limited alopecia, and can ease patients into the course of their disease. So I don't think every single patient has to have an ADC first line. But of course, the more aggressive disease is, the more likely we are going to choose an ADC.
So we were talking before about the survival benefit that we saw with the Dato study, but Peter got into all the issues in terms of really interesting too with the U.S. versus non-U.S. or the difference in geography in terms of access to second-line therapy. Bottom line, it sounds like, Melinda, you say you choose between the two based on side effects. So the question we put out here is, globally, do you feel like efficacy of these two agents is the same? I'm going to assume your answer is yes, because you say you're really you're not choosing it for that reason. You're choosing for sort of a side effect reason. Is that accurate? Is that the way you see it, Melinda?
It is. I think the drugs are very similar. Peter sort of described it very well, the issue around the overall survival that was seen with the TROPION-Breast02 study, which has not yet been observed with ASCENT-03. But I think really key differences, and you need to, our trials are increasingly global, and in many areas of the world, access to second line or third line treatment, there is no access even for later line chemotherapy, let alone ADC. And so it really affects interpretation. And I think in the ASCENT-03 trial, the crossover was part of the design, and patients on the control arm were offered SG at progression. And that was not the case with TROPION-Breast02. And so while there was a survival advantage, I don't think that it's really fair to say that there's truly an overall survival benefit when the control arm patients did not have access to second line TROP2 ADC.
So, Peter, it seems like years since Dr. Telli presented the SASE plus Pembro data, but it's actually only a year ago, actually. So much has happened since then. The ESMO, so many great things came out. Let's talk about the PD-1 positive patient and the data that we have and the data that we're looking forward to, Peter.
Yeah, so this is a very similar trial to the PD-1 negative trials, but this instance in PD-1 positive patients. So everyone has an immune checkpoint inhibitor, pembrolizumab, and then patients are randomized between sacituzumab govitecan plus pembro versus standard chemotherapy plus pembrolizumab. Similar to the ASCENT-03 trial, the trial did not include patients who relapsed within the first 6 months after the end of their therapy, and had about 20% of patients relapsing between 6 and 12 months, and then the rest later on a de novo metastatic disease. Again, similar to the PD-L1 negative trial, 81% of patients who received sacituzumab govitecan as a second or subsequent line therapy funded as part of this trial, which I think is really remarkable. Progression-free survival, significant and meaningful improvement. What I find particularly, again, if you look at the TROP2 results, the benefit is seen regardless of patients have low or high TROP2 expression, although we see possibly slightly more activity in patients with higher TROP2 expression. One of the data I find particularly exciting is the duration of response. If you look at that 9 versus 16 months, 16 months is a remarkable duration of response, something we didn't think would be possible in metastatic triple-negative breast cancer. And go back to my very first slide with a median survival of 12 to 15 months only a few years ago. This is the duration of response of your first-line therapy, and I think that's important. Progression-free survival, similar pattern. The benefit is carried over into the next line of therapy, which is important for patients. And if you look at the response rate, there's a small but important difference. The higher response rates is something we see with practically all ADCs compared to standard chemotherapy. What's the cost in terms of side effects? A very similar pattern to the single agent sacituzumab govitecan trials, more gastrointestinal toxicity, diarrhea, a lot more neutropenia compared to standard chemotherapy. But all of that, and we'll talk about that, is manageable. And interestingly enough, the discontinuation rate was lower ultimately with sacituzumab govitecan compared to standard chemotherapy. And we also see here an increased time to deterioration in quality of life and physical functioning, which just emphasizes the importance that if we give these treatments early on, patients will ultimately do better. I think the last slide here is almost leading us over into the sequencing discussions we have then second and third line. But what drives resistance to ADCs? These are now data that are a few years old with sacituzumab govitecan, looking at serial biopsies of patients who progress on sacituzumab govitecan. And in a nutshell, you can see resistance either down to the target, so the antibody doesn't bind the cell surface anymore, or to the payload, in other words, the chemotherapy drug. And what's really interesting to see in this trial, that in the very same patient, we may see two different mechanisms of resistance. And what it teaches me is that the resistance is often subclonal, which means not every part of the cancer is showing the same mechanisms of resistance. And clinically, we see something now more often than what we used to see with standard chemotherapy. That's a phenomenon called oligoprogression. If you have 10 sites of disease, 9 are responding, 1 is growing, do you change the whole therapy, or do you just give targeted therapy, for example, radiotherapy, to that one site? That's something we see more often with ADCs, and I think that's important clinically when you develop the strategies for patients.
And actually, Peter has a case where this comes up, but we're hopefully we'll get to. So back to the real world, Melissa. Of course, one of the questions, and one of the first question people started asking when they saw this N04 was, what about patients who'd gotten prior Pembro, for example, the Keynote 522 regimen? That's what you see here in this woman who's 40 years old. But the difference was this lady actually got type 1 diabetes after 2 doses of the Pembro, and then it was discontinued. And she later on relapsed. And the question is, first of all, would you use an IO in somebody who got, it seems like if you have type 1 diabetes, you have it. I'm not sure it's going to change by keeping more. So would you consider, IO, for example, SASI and Pembro in a patient like that, Melinda? And also, how do you decide if a patient's had a prior, full course of prior, say 522, whether or not to add an IO if they're PD-1 positive in metastatic disease, Melinda?
Yeah, I think in breast cancer, the ground is always shifting beneath our feet. And, it is a really important question about whether if the patient recurred after adjuvant, neoadjuvant pembrolizumab, would they get a benefit in the metastatic setting? And so I think for me, I think about how long it was, that interval between when they completed their adjuvant pembrolizumab and when they recurred. I think if it's more than a year, then I would likely give it again. I think if it's a really short period of time and they recurred on or shortly after completing their adjuvant pembrolizumab, I think that likely I would not continue it. But these are some of the scenarios that we're facing now in clinic for sure.
Peter, anything you want to add to that? And also kind of getting back to this question of a site of metastasis, does that affect you? So theoretically, if you could, or would you give, for example, SASI plus Pembro to most patients? And what about if they have brain mets and they're HER2 low? Would you think about TDXD before a TROP2 ADC?
So, I mean, I like the combination of an ADC and an SG with immune therapy. I think it's highly active. I think the duration of response is really impressive. I have a very low threshold for re-challenging patients with an immune checkpoint inhibitor. I think there's very little to lose. The toxicity, if they had their pembrolizumab as part of the neoadjuvant regimen, it's very unlikely that they will get significant toxicity in the metastatic setting. And by the way, if a patient has diabetes, that's extremely rare. I've seen this more in one patient out of probably 1,000 patients I've treated. And once you have diabetes, you have diabetes. It's not a reason to stop a checkpoint inhibitor. I would re-challenge those patients. There's an additional thought is ADCs are massive microenvironment disruptors. In other words, they break down the structure of the tumor. It leads to an influx of CD8 positive cells. And there's the theory that giving an ADC may turn tumors that are cold and don't respond to immune therapy, now it make them hotter and allow immune therapy to work. So in theory, if a patient had immune therapy as adjuvant on their own, it may not be the most effective way of giving immune therapy. If then the patient has disease recurrence and we want to combine it with an ADC, it is possible that we render the tumor sensitive again to the checkpoint inhibitor. So I would always bring that back in.
So just to pick up, though, on that point that you brought up, Melinda, if you were to have a patient develop type 1 diabetes, and this patient actually had the Pembro stopped, would you have actually kept it going?
Of course.
I mean, I think it's a discussion with the patient. I think patients who do have immune-related adverse events, they are at risk of additional ones. I had a patient who in the curative setting developed type 1 diabetes and then wanted to go on a clinical trial of immune therapy for PD-L1 positive disease at metastatic recurrence. And then she did unfortunately have a subsequent, just a different but severe immune-related adverse event. So I think those patients that experience one event, they do have elevated risk for subsequent. But it's a discussion with the patient. She really wanted a shot at immune therapy again and was willing to, kind of accept the risk of immune-mediated toxicities. She's now permanently discontinued because of her most recent event.
Melinda, do you believe this comes up in all the diseases and cancers where IOs are used? Do you think there's a relationship between autoimmune toxicity and treatment benefit?
Yeah, it's really interesting in this patient. She had really major liver metastasis. And when at the time of recurrence, the immune therapy was brought back in, she's had an absolute complete resolution of her distant disease. The only active disease she has is kind of nodal local disease. So really interesting. I'm very intrigued by, that response in her liver. And so, I think that, there may be something to that, right? So she had a few serious, really uncommon adverse events, but has had this really excellent response, which she's maintaining at this point.
I think in lung, they've shown a correlation with people who get COVID vaccines and benefits from IOs. I don't know, maybe stimulating the immune system might be something else that might be a factor here. All right, Peter, you referred to the issue of sequencing. And particularly here, we have the possibility in many of these patients to use a TDXD for HER2 low or ultra low. Let's talk about the data.
Yes, if you first look at data of TROP2 ADCs in pretreated metastatic disease, and this is how the development actually started, the very first data of sacituzumab govitecan you see here, phase 1 trial in patients with 3 or more lines of chemotherapy for triple-negative breast cancer. And if you see a lot of patients with TNBC, you know nothing really works in that setting. And having a response rate here of around 33% was remarkable to see, with a duration of response of nearly 8 months, and progression-free survival of 5 months. So the question in those early trials was, is this patient selection? And what you see on the right side of the slide is patients with the immediate prior therapy in red and then sacituzumab in blue. And if you go, for example, down from the top third or fourth patients, you can see she progressed within 2 months on the chemotherapy before and then stayed on sacituzumab govitecan for nearly 2 years. So it's clear it is activity of the drug, not just patient selection, that drove that benefit in early studies. When we looked at the first phase 3 trial that came out in pre-treated patients, 2 prior lines of therapy, sacituzumab govitecan versus treatment of physician's choice, it wasn't a surprise that the primary endpoint was highly significant and meaningfully improved hazard ratio of around 0.4, trebling of the median PFS from about 1.5 months to about 6 months. That also was associated with a clear doubling in overall survival to about a year. And again, a substantially higher response rate, 5%. That is what we see with standard chemotherapy in those patients, 35% in heavily pretreated patients with sacituzumab govitecan. I mentioned right at the beginning, non-approved drug in the US or Europe, sacituzumab TMT. So similar antibody, but slightly different payload, same class, very similar data in Optitrop breast, one pretreated patient, again, progression-free survival, significant, impressive improvement. We see the same in overall survival. And again, we see the same dramatic shift in response rate. So it's very clear that those ADCs don't just work in a first-line setting, but also in a second-line or third-line setting. But what to do if a patient already had an ADC? Can we give a second ADC? And I think the data are a little bit disappointing at this point in time. These are real-world data. You see in red ADC1, which was SG, and then in blue ADC2, which was TDXD. And essentially, yes, there is activity, but it is substantially less for the second ADC and probably goes down to a third or a quarter of the activity of the first-line ADC. Again, similar here. Time to progression ADC1 versus ADC2, we see some activity, but not very high, which is not a surprise. If you give docetaxel after paclitaxel, you won't expect a dramatic response. And the majority of the resistance is probably driven by the payload rather than by the target.
So we'll get into this question in a second, and then we're going to talk about toxicity. But first, Melinda, interesting case from the chat room. I never thought about this. This is from Hassan, 55-year-old woman, initially diagnosed with ER-positive HER2-0 disease. Gets riboletrozole for a year, bone mets, so only for a year. Progresses, has a PIK3 mutation, gets a capi fulvestrant for 6 months, rapid progression in the liver. But now the biopsy says triple-negative disease, and the PD-1 is 10. So this patient who was originally ER positive now is showing triple negative with a positive PD-1. You certainly can just consider SASI, but what about SASI and Pembro in this patient, Melinda?
I think we do see these cases. Whenever we do, we try and do whatever we can to make sure that it's accurate, that the biopsy, which is calling triple negative breast cancer, is accurate, and that it's not just actually a hormonally driven tumor. But this does happen sometimes with progression. ER is lost and patients become triple negative. And so I think in that setting, if you have the biopsy and the PD-L1 positivity, I think that yes, you could go either Pembro chemotherapy or apply ASCENT-04 and SG pembrolizumab for that patient.
So he also wants to know what's the value of TILs in triple negative? Is that something you integrate into your decision?
Yeah,
Melinda?
I mean, I think there are a number of studies in early breast cancer that have shown, the prognostic importance of TIL. It has been assessed as well in advanced breast cancer, triple negative breast cancer to a lesser degree. But at this point in time, it's not universally reported. Sometimes pathologists will comment on it if it's a really robust infiltration with lymphocytes in the tumor. But at this point, interesting, but not yet kind of relevant for my clinical practice.
So, Peter, I'm kind of curious now. We talk about PD-1 positive patients who typically are going to get ADC, in this case, sacituzumab with an IO, pembrolizumab. But looking at this next scenario, how do you think about second-line therapy in patients who get, first of all, pembro chemotherapy, taxane, for example, and also pembro sacituzumab with second line in HER2 low and with second line in HER2 zero, if you ever see that?
So it's the question whether we would give a checkpoint inhibitor then second line. I mean, ultimately the ADC works whether it's first or second line. And if the patients didn't receive an ADC first line, it is equally the most effective therapy in second or third line setting. Whether one would still add a checkpoint inhibitor in there is obviously a difficult question. We saw the activity with the initial chemotherapy studies. The immunotherapy trials were positive in a first-line setting, but not in a second, third-line setting. And as the tumors become a bit more immune suppressed, I think it's more difficult to launch an immune response. So if you want to give immunotherapy, give it as early as possible.
So, of course, another option, and these options are getting a lot more exciting nowadays, is participate in a clinical trial. Kind of once you get beyond TROP2 ADC and TDXD, if you can, things are kind of challenging in terms of finding effective therapies. Peter, I was curious because we did a program over the weekend focused on VEGF PD-1 bispecific antibody, particularly ivonescimab. We've seen a lot of interesting data there with lung cancer. I know in the past, actually, bevacizumab has been used in triple negative disease. That sort of went away. Any exciting trials going on right now for these patients with metastatic disease, Peter? And any thoughts about ivonescimab? And there's also other experimental bispecifics out there in triple negative breast cancer, Peter.
There's a number of bispecific antibodies being developed targeting on the one hand PD-1 or PD-L1, on the other hand VEGF, and ivonescimab is a drug, pumitamig is a different examples, and they have all shown very encouraging data in non-randomized first, second-line trials with high response rates, not just in PD-1 positive, but also, interestingly enough, in PD-1 negative tumors. And we know that VEGF is a factor, a driver of resistance to immune checkpoint inhibitor therapy. And there's also, we know if we give anti-VEGF targeted therapy, it can increase the influx of immune cells into the tumor. So the hypothesis is really, can we make that work? Can we make immune therapy work in PD-1 negative tumors? There are phase 3 trials ongoing, for example, Rosetta, a trial with pumitamig chemotherapy and pumitamig versus chemotherapy in PD-1 negative tumors. So that is the exploring whether a bispecific ADC targeting PD-L1 and targeting VEGF can improve the outcome in tumors that would normally not be candidates for immune therapy. And I think that's really interesting.
Yeah, it's really amazing. At ASCO, there was a first-line phase 3 study. It was done in China, looking at ivonescimab chemotherapy compared to pembro chemotherapy, and it beat pembro, which is really amazing when you think about the possibility that maybe in some of these patients we're going to be using a bispecific rather than single-agent IO maybe in the future. All right, well, we kind of referred to some of the adverse events and how they affect your treatment decisions. I want to explore that a little bit more and also get into a lot of the granularity, what you actually do with your patients to prevent or manage these complications. Melinda, you put together a great talk summarizing that.
All right. Well, we'll get into this last section, and I want to start off with a case. This is a 67-year-old woman initially diagnosed with a very early stage tumor. It's T1 Mike N0 in the right breast. She had a larger area of DCIS. The invasive disease, though, was triple negative. She had lumpectomy, had whole breast radiation, and she was recommended for no systemic chemotherapy given the very small size of her tumor. She did have family history of breast cancer, so she did genetic testing and tested negative for any germline pathogenic variants in BRCA1 or 2. So fast forward 2 years, now 69 years old, she goes in for a routine mammography and is found to have suspicious right axillary lymph nodes. This is worked up, biopsied, triple negative, local recurrence confirmed, has a PET scan, and it shows really extensive local regional nodal disease, but then also, unfortunately, some low cervical and mediastinal nodal disease. Mediastinal node is biopsied, and it is triple negative breast cancer, PD-L1 negative, CPS of 1, and next generation sequencing interestingly reveals a somatic BRCA2 pathogenic variant. So for treatment in the first line, so this is a treatment-naive patient, never had anything in the curative setting. She's 69 years old. She initiates SG, standard dosing, 10 milligrams per kilogram IV on days 1 and 8 of a 21-day schedule. You see her for cycle 1, day 8, and her labs come back with a grade 3 neutropenia. ANC is 700. So you have to hold her, initiate GCSF. She has really prompt improvement, able to move forward with delayed day 8. But that same day, she comes in endorsing 5 to 6 loose bowel movements per day over her baseline. So that's a grade 2 diarrhea. You did prescribe her loperamide, but she didn't take it. And so you have her start loperamide BID, and that leads to prompt improvement to grade 1 diarrhea. So I think this is a pretty typical case in terms of what we see in our patients with SG, some of the common side effects we need to manage.
So I want to get into that a little bit more, and you're going to get into it with the slides. But Peter, you also had a case of a patient who got sacituzumab and also had a problem with diarrhea. But just to come back to you, first, Melinda, what prompted you to give her the SASI as opposed to a PARP inhibitor, for example?
Yeah, I think this patient and everyone involved in her care was sort of floored that she had a metastatic recurrence. She had a very small tumor, a T1 Mike, node negative, and then here we are 2 years later with recurrence, was oligometastatic. And so, she was just so upset and distraught about everything, really wanted to go for it with the goal that if we get a good response, given that it was oligometastatic, could we potentially consolidate with radiation and try to improve her long-term outcome. Olaparib would have been an option. She has somatic BRCA2 mutation. Oftentimes patients do like to start with that when there's an option just because it sort of eases them in. But I think the motivations for this particular patient were different, and she wanted to go for the most effective treatment. And so we went with the TROP2 ADC SG.
And what's her current status? Of her neutropenia and diarrhea still problems, or not really?
No, she's taking GCSF, taking her loperamide, learned that lesson, and so in response, doing well a few months in.
And Peter, you also had a patient, again, when SASI had an issue with diarrhea. I'm curious whether or not you still see very much diarrhea with sacituzumab. Peter, I don't hear people talking about it as much as I hear neutropenia.
No, I think it's a really important point, Neil. And this is a case from the early phase when we weren't quite as experienced with sacituzumab govitecan as we are now. I haven't really seen diarrhea in the last 2-3 years. One of the reasons for that is we give triplet or quadruplet antiemetic prophylaxis with steroids, with all the different drugs. So that causes constipation. I see now more constipation in patients with sacituzumab govitecan than actually diarrhea. We give them loperamide to take it home. And actually the whole side effect spectrum has changed dramatically. Also with the addition of prophylactic GCSF, neutropenia isn't really a problem anymore. So the tolerability with our learning curve has changed dramatically.
and we'll get into data in a second. But let's go back to your slides here, Melinda. Can you talk about particularly this comparison?
Yeah, so I wanted to talk a little bit about some of the unique aspects of these two drugs. These are our two approved agents for metastatic triple-negative breast cancer. Same antibody is recognizing the same antigen, very similar payload, but we see very different toxicity profiles. With SG, more chemotherapy-like side effects, neutropenia, some diarrhea, nausea, fatigue. With Dato-DXd, nausea is an issue, but we also have issues, the ocular toxicity, ILD or pneumonitis, and then, as was mentioned earlier, stomatitis is a unique side effect associated with Dato. So Peter covered this, and I think the big takeaway from the SG ASCENT-03 trial, which looked at SG monotherapy versus chemotherapy. Patients were on the SG for a longer duration compared to chemotherapy. And overall, the rates of high grade and serious adverse events were quite similar despite the longer duration. And there were actually fewer patients with adverse events leading to a dose reduction in the SG arm compared to chemotherapy. I think one thing we saw in ASCENT-03, which is a little bit of a surprise, was that there were 6 deaths in the SG arm. This wasn't observed in ASCENT-04. But these were all patients who had risk factors for neutropenia, febrile neutropenia, and did not get primary prophylaxis, and they died of infections. And so it is something to just be mindful of. It was updated in the FDA label, this need to really think about patients who are appropriate for primary prophylaxis for neutropenia and neutropenic fever. If we look at the major adverse events, neutropenia, nausea, alopecia, we mentioned, common with both drugs. Diarrhea and fatigue are really the big ones with SG. And for nausea, it is considered to be highly emetogenic, so it is recommended that patients pre-medicate with a highly emetogenic risk program. So dexamethasone, a 5-HT3 receptor antagonist and an NK1 receptor antagonist. Neutropenia, considered intermediate risk by NCCN guidelines, need to think about primary prophylaxis for those patients with risk factors. If they had prior chemotherapy, if they're coming in already a little bit neutropenic, if they're older, organ dysfunction, poor progression-free survival, performance status, that should be, that those patients should all be considered for primary prophylaxis. Diarrhea, loperamide is really an active agent. You need to think about ruling out an infection, other supportive measures like hydration, and just a couple other things with the SG infusion reactions. If they have a history of that, you need to think about pre-medicating with antipyretics, H1, H2 blockers, and corticosteroid. And if there's a history of a cholinergic reaction, atropine. So a couple things to keep in mind with the orders. There was a study primed. We wanted to just touch on this a little bit. So this was a clinical trial looking at patients, metastatic, triple negative, or ER positive, HER2 negative disease. They had to have had received at least 1 and up to 2 prior standard of care regimens. All patients were planned for SG at standard dosing. And this was a strategy where for the first 2 cycles, patients received loperamide 2 milligrams BID or 4 milligrams once a day for 3 days after each weekly dose, and then also received standard GCSF for 2 days after each weekly dose in the first 2 cycles. And the goal was to look at the incidence of grade 2 or higher diarrhea, grade 3 or higher neutropenia. And what you can see with this sort of upfront prophylactic primed approach is that there's lower grade neutropenia as well as diarrhea, especially some of the high grade events with this approach. So really useful to think about prophylaxis. As Peter mentioned, sometimes when you prophylax with loperamide, you do run into issues with constipation. And so that is just something to keep in mind too. This is how these adverse events for neutropenia on the left, diarrhea on the right. The gray bars with this prime strategy, the blue and red are some of the phase 3 trials with SG that did not employ this approach. So much higher grades and higher prevalence of these adverse events. So moving to the next case, we're going to shift gears a little bit. So this one is a 54-year-old patient. She self-palpates her right breast mass, gets it worked up, 4.8 centimeters on imaging, multiple axillary lymph nodes, core biopsy, it's triple negative. HER2 IHC is 1+. She has a staging scan that just shows local regional disease, breast, axillary lymph nodes, internal mammary nodes. Clinically staged as 3C, anatomic staging. So she gets Keynote 522. Overall assessment is that she's having clinical response. She then proceeds with mastectomy and axillary lymph node dissection. No primary tumor in the breast, but she does have multiple lymph nodes, 12 out of 21 in the axilla, and so has a pathologic stage of YPT0, YPN3. She is referred and initiates post-mastectomy chest wall and regional nodal radiation. In the middle of that, she has a new sort of area of erythema. It's thickened on her, along her mastectomy incision. It's biopsied and consistent with recurrent triple negative breast cancer right in the midst of radiation. She has restaging and she now has metastatic disease, mediastinal lymph nodes, and in the lung. So I think that this is a patient really good for Dato-DXd. So in that trial, as Peter, reviewed, this trial was unique, TROPION-Breast02, in that there was no minimum disease-free interval. So patients who were recurring on adjuvant pembrolizumab, early post-surgical recurrences, those patients were eligible. So this is a patient, I think Dato-DXd is a good fit. Standard dosing, 6 milligrams per kilogram, IV every 3 weeks. So she starts her first couple cycles. She's having clinical response on her chest wall. So you're pleased with that. But then she comes in for cycle 3, reporting increase in oral pain, multiple mouth sores. She is able to eat, but she says she's having, pretty substantial pain and can only tolerate liquids and really soft foods. And when you query her, she says that she has not been compliant with her prescribed dexamethasone solution. And so I think this is, again, a common thing that we see. We talk to the patients about some of these side effects. We recommend the prophylaxis, but patients are somewhat variable in their compliance with some of these prophylactic recommendations. So TROPION-Breast02 overall safety summary, I think pretty much a similar story. Longer duration of treatment with Dato-DXd in this study compared to chemotherapy, but we saw fewer discontinuations with Dato-DXd compared to chemotherapy, pretty similar rate of high-grade adverse events and serious treatment-related adverse events. If we look at what we see with Dato-DXd, we're seeing more ocular events, so dry eye. We have the mucositis, stomatitis, which is more common than chemotherapy, and then nausea was actually more common with Dato-DXd compared to chemotherapy. And on the other side, the neutropenia, anemia, leukopenia was much more with the chemotherapy arm in this study compared to Dato-DXd. And so if we look at these adverse events of special interest, we talked about this, but oral mucositis stomatitis is definitely an adverse event that you need to be aware of. So you can see the breakdown by grade. Grade 1, 24% with Dato-DXd, grade 2, 27%, grade 3 or higher, which is really patients being unable to eat, 8%. Ocular surface toxicities, also common. Most of these are lower grade, but there are some higher grade events. And this can be dry eye, keratitis, conjunctivitis. And so really important to think about that. And then don't forget with Dato-DXd, there is an ILD risk. It is lower than what we see with T-DXd, but one needs to be mindful of that and screen patients and inform them about that risk.
So maybe just in the interest of time, Melinda, because we're kind of running out of time here, you just kind of summarize a little bit about what you do when you start a patient on Dato-DXd in terms of prevention of these issues and also monitoring for ILD.
Yeah, so I think with Dato-DXd, you really want to impress upon the patient some of these key recommendations. So for the dry eye, they need to have an eye exam at baseline, at least 4 times a day, a preservative-free eye drop, really more the better, up to 8 times a day. They should avoid wearing contact lenses. This is a problem for some patients. And then for the mucositis risk, it's really the steroid mouth rinse is very effective in preventing this. 4 times a day for an oral dexamethasone solution, swish. And there, have been some strategies looking at patients sort of chewing on ice chips during the infusion. Potentially, that can help to mitigate some of the mucositis risk. More needs to be sort of learned on that. And then I think for the ILD monitoring, very similar to what we do with T-DXd and HER2. And so I think that that should be the approach.
Peter, anything you want to add to that? I hear a lot of patients have a lot of concerns who wear contact lenses. I kind of wouldn't think that'd be a huge issue, but how do you find people tolerating Dato-DXd, and anything you want to add to what Melinda just said?
I think a couple of things to consider. So the first thing is we haven't had quite as much experience with Dato as we have with SG. And if I think back to where we were with SG 5 years ago, we struggled with some of the toxicity. Now we manage that, and it's a very well-tolerated drug. I'm confident we get to the same point with Dato-DXd. The eye toxicity in real life is not really an issue. We see very little of that, and that's easily manageable. It's just a bit of a nuisance having to have an ophthalmologist as part of your team, but otherwise it's not a problem. The stomatitis is not that easy to manage for us at the moment, but we have predominantly experience within trials where we can't sort of reduce the dose subtly as we would do outside clinical trials. And I think that affects 90% of patients are fine. It's a small percentage of patients where we struggle with that stomatitis. And I'm confident that we will do better in a year or 2 years' time with more experience.
So Melinda and Peter, thank you so much for working with us today. It's a very informative audience. Thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Melinda. Peter, thank you so much.
Thanks,
Thank you.